Hello, guys. So today we are going to start our new series where I will be explaining therapeutic guidelines. I'm going to make therapeutic guidelines very simple for you. I'm going to be explaining it in simple words and summarized manner. I'm going to be mentioning and highlighting the important points and important text that is important for AMC, and which points AMC test, and what are the tricky questions that it can ask you from the management of different diseases. So now I'm going to start with the respiratory module. Now coming towards our first topic of respiratory module, that is COPD. In guidelines, I'm not going to be sharing the basic theory that you have already covered in school. What I will be sharing is that what are the important pointers for AMC and what is the Australian specific management, right? So, starting with COPD, on the basis of management, COPD can be divided into stable COPD when the patient is stable symptoms of COPD versus the acute exacerbations of COPD that has different management, and we are going to be doing the COPD exacerbations in different video. Now, coming towards the diagnosis, stable COPD cannot be diagnosed without spirometry. The diagnostic test for COPD is spirometry, and the diagnostic feature of COPD is that the FEV1 to FVC ratio is less than zero point 0.7. It is the diagnostic of COPD, right? Now, coming towards the stepwise management of COPD. COPD has actually the non-drug and drug therapy. In non-drug therapy, we are going to be starting with the general measures. General measures can be considered adequate for the patients who have few symptoms, and the symptoms and the COPD assessment test score is less than 10. So general measures can be adequate. On number one, and very important point, a very important part of the general measures is that smoking cessation. As COPD is caused by the heavy exposure of tobacco, smoking cessation is the number one management or general measure that is going to benefit the patient, and it is the single most important intervention to prevent or limit the lung damage in COPD. Once the COPD is diagnosed and patient starts to develop COPD, it cannot be cured, but we can slow the progress of COPD. And by smoking cessation, it is the simple general measure without drug therapy. The patient can slow the progress because the patient suffers from shortness of breath. But if the patient increases his tolerance of physical activity, then the risk of hospitalization gets decreased. Then we have a very important part that is pulmonary rehabilitation. Pulmonary rehabilitation is very important in managing COPD. It increases the quality of life and increases the exercise capacity. Actually, it comprises of exercise education, behavior modification, and outcome assessment. Pulmonary rehab. See, the patients of COPDs, they need vaccinations of pneumococcal and influenza because they are at higher risk for contracting these infections. Nutrition, BMI, these patients should maintain their BMI in healthy range, and they should maintain good nutrition. So these are the general measures. In drug, now starting with the drug therapy. Before the drug therapy, I want you to see the classification of COPD according to the severity. So according to the severity, COPD can be mild, moderate, and severe. And this classification is on the basis of symptoms, exacerbation, and lung functions. So, if the patient is breathlessness on moderate activity and there is cough and sputum, the patient can have the mild COPD. In moderate COPD, the patient would be having breathlessness on walking on ground level. There would be recurrent chest infections, and the exacerbation that the patient experience would be requiring oral steroids or antibiotics to get treated. In severe COPD, the patient will be having SOB on minimal exertion, and the frequency and severity of exacerbation would be increased. According to lung function, FEV1 is 60 to 80% in mild, 40 to 59% in moderate, and less than 40% in severe. Now, starting with the drug therapy, if the symptoms are mild and infrequent, so the patient is advised general measures and short acting beta agonists. And after say 3 months, the patient is assessed and the patient remains symptomatic. We are going to step up therapy, that is a LABA, a long-acting beta agonist, or LAMA, that is long-acting muscarinic agent, and these are used as monotherapy. And along with them, the SABA can be required as rescue medicine. So at this step, either LABA would be used or LAMA, and these improve lung function, improve exercise capacity, decrease frequency, and decrease the severity of exacerbation. After that, patient still remain asymptomatic. Now we are going to step up the therapy to dual therapy, that is LABA plus LAMA. LABA or LAMA are both given. Patient remains symptomatic. We are going to towards the triple therapy, that is LABA, LAMA, and inhaled corticosteroids. If the patient remain symptomatic, we are going to refer the patient to the respiratory physician. Some important points in drug therapy are that along with SABA, SABA can be used, and or ipratropium can also be used in the first step of the management when the mild and infrequent symptoms are there. But ipratropium is contraindicated in the COPD patients for symptomatic relief in patients who are taking LAMA. For example, if the patient is stable and he is on the therapy of LAMA and he gets acute exacerbation. So in acute exacerbation, we are going to first administer the short-acting bronchodilator. That can be SABA or ipratropium. But ipratropium is contraindicated when the patient is on LAMA because it increases the risk of cardiovascular events, right? An important point when administering the triple therapy is indicated when the patient remains symptomatic despite the dual therapy, and or if the patient had a severe exacerbation which required hospitalization, or at least two moderate exacerbations in the late 12 months. Means if the patient in the last year, if the patient has had severe exacerbation of COPD that required hospitalization, or at least two moderate exacerbation in the last year, the patient would be the candidate for triple therapy. We also have the additional therapy for severe COPD. If the patient has not responded or remained symptomatic after the triple therapy, we are going to consider it as severe COPD, and there can be additional therapy for severe COPD patients. We have domiciliary oxygen therapy. It is for the patients who have advanced COPD and they have significant hypoxemia, and the oxygen saturation is less than 90%. So for domiciliary oxygen therapy, the patient is required to have the ABG to determine the eligibility for a DOT, and we have to assess the ABGs while the patient is stable and not within the 4 weeks of an exacerbation, as it can alter the results. And gases are not in the correct form, they can fluctuate. Now, coming towards the home non-invasive ventilation. Home non-invasive ventilation is advised for the patients who have COPD and persistent hypercapnia. If the patient has hypercapnia, we are going to be giving him non-invasive ventilation, and the patient can also home non-invasive ventilation. And if the patient is still do not require and he is gone under the complications of COPD, we can go towards the invasive ventilation. Other drugs that the patients of COPD use are mucolytics for the sputum, long-term macrolides, antibiotics for infections. Theophylline is not recommended to treat COPD in Australia. Lung transplantation and surgical options can also be considered in patients and selected patients with end-stage COPD. When are we going to refer the patient of COPD to the pulmonary specialist? If the diagnosis is uncertain, there are frequent exacerbations and persistent symptoms despite the drug and non-drug therapy. Especially, pulmonary rehabilitation has also been done along with all of this management, and the patient has not responded and has persistent symptoms. There are unusual symptoms, for example, hemoptysis. There is rapid decline in FEV1. COPD is diagnosed and suspected in less than 40 years, because COPD is after the 40 years is diagnosed and is presented after the 40 years. So if COPD is in less than 40 years of patient, we have to refer the patient so that he can investigate the alpha 1 antitrypsin deficiency. So there is a guideline that we have to review and assess the patient, and take the follow-up of the patient after the therapy. If the patient has mild to moderate disease, we have to assess the patient annually. And we have to check the patient for if he needs referral, or if he has cessated smoking, if there is hypoxemia, exacerbations, if there are any psychological comorbidities, drugs adherence, and their side effects. And we are going to measure FEV1, FVC, and COPD assessment score, CAT score, and BMI. And if the patient is of severe COPD, we are going to test all of this, all of the above, and plus we have to assess the complications of COPD. That can be cor pulmonale, any cardiovascular disease. If the patient needs long-term oxygen therapy, referral for surgery, and live discussions. And for severe COPD, the review is at least 2 times per year. And in case of severe COPD, we are going to measure ABG if the oxygen is less than 90%. The patient can also have the self management, and for that, the practitioner should give the patient a written action plan, where there is all the management plan of the patient, and instructions for the patients to self manage. Now, coming towards the comorbs and complications of COPD. Number one, asthma. Asthma most of the times can coexist with the COPD, that is termed as the overlap asthma COPD in patients. And if the patient has COPD, he has an increased risk of COPD. What can be the differentiating features between these two is that asthma is most of the times presented in less than 20 years, while COPD is presented in more than 40 years. In COPD, there is persistent airflow limitation, while in asthma, there is variable airflow limitation day to day. The COPD patients do not respond, and they lack response to the asthma treatment. That's why the inhaled corticosteroids are not recommended as a first line in COPD patients, while in asthma they are recommended. They are a recommended asthma therapy. And in asthma patients, they have night symptoms, and also they have a family history. Also, COPD have a history of is associated with a very high exposure of tobacco. Asthma can also be aggravated with the tobacco exposure, but in COPD, tobacco is the main causative agent for COPD. If the patient has coexisting asthma and COPD, that is overlap, we are going to take the specialist advice, and we are going to give the therapy of ICS, that are inhaled corticosteroids for the asthma, and long-acting beta agonist for COPD. So this would be the management for if the patient has coexisting asthma and COPD. Now, if the patient has a comorbidity of heart failure, cardiovascular disease, and if the patient has heart failure with reduced ejection fraction, so heart failure patients are advised beta blockers. And if the patient of COPD has a comorbid of heart failure, beta blocker can increase and result in severe and very severe exacerbations, and they can increase the mortality. The patients of COPD can get severe exacerbation if they are exposed to beta blocker, but in heart failure patients, beta blocker are very necessary for the treatment. purpose, it's still we do not have to withhold the beta blocker on grounds of coexisting COPD. We are going to give, if the patient has COPD, we are going to give the patient, if the patient has COPD along with heart failure, we are going to give beta blocker, ignoring the fact that the patient can have exacerbation, because beta blocker is very necessary for the patient of heart failure. But we would be giving the beta blocker very cautiously. Anxiety and depression. Anxiety and depression is common in COPD patients. For that, pulmonary rehabilitation is important and it can reduce the symptoms of anxiety and depression. The COPD patients also have a high risk of osteoporosis and can increase the risk of fractures. COPD patients also have the increased risk of diabetes, and the patients who have diabetes and are advised high dose inhaled corticosteroids for COPD can have increased diabetic complications. Another complication for these were the comorbs. Now, pulmonary hypertension is a very important complication of COPD. There is an increased risk of exacerbation and increased mortality associated with pulmonary hypertension, and we are going to refer the patient to specialist. Cor pulmonale is the right ventricular hypertrophy and dilatation, and it is the right heart failure, which is secondary to the lung disease, and it is termed as cor pulmonale, and it is suspected when the patient has the symptoms of right heart failure. Late stage COPD. How are we going to suspect late stage COPD? If their symptoms are getting severe, like their patient has severe dyspnea, severe cough or increasing frequency cough, fatigue, the patient is suffering from social isolation, anxiety, and depression, we are going to suspect late stage COPD. What are the signs? FEV1 is less than 25%. There is oxygen dependence. Respiratory failure is there, that is causing hypercapnia. Heart failure signs can also be there. Weight loss or cachexia, decreased functional status of the patient, advanced stage, and the dependence on others for living. In this condition, end of life discussions are to be held with the patient in the OPD setting when the patient is relatively stable.